So next condition we are going to discuss is Polycythemia vera. So this condition, it is characterized by increased production of all the myeloid elements that results in pancytosis. That means there would be increased red cells, granulocytes, as well as platelets without any recognizable cause. So it can be, remember, it can be primary or secondary. The secondary polycythemia vera, it can occur due to high altitude, or due to cardiovascular diseases, or due to pulmonary diseases, or due to smoking, heavy smoking. All these are causes of secondary polycythemia vera. Other causes could be increase in erythropoietin, like in case of renal cell carcinoma, there is increase in the erythropoietin level, plasma loss from the burns, etc. Now, what could be the etiology? So, the major pathogenetic mechanism that is involved is here is a tyrosine kinase mutation. That activates the kinases. Now, what would be the clinical feature? It generally occur in middle life, and it is more common in the males. So it runs a chronic but slowly progressive course. The clinical features you will see due to the hyperviscosity, hypervolemia, hypermetabolism. So there would be headache, vertigo, tinnitus, syncope, increased risk of thrombosis due to atherosclerosis. There could be increased risk of hemorrhage. There could be increased hemorrhage that could occur due to increased blood volume and intrinsic platelet dysfunction. Apart from that, splenomegaly may be seen, pruritus may be seen, or there may be increased risk of urate stones, gout may be seen, and this polycythemia vera, it is diagnosed by following hematological findings. So there is, first of all, there is a raised hemoglobin concentration. You will see the hemoglobin is above 17.5 gram per deciliter in males, and in females its value is 15.5 gram per deciliter. There would be erythrocytosis. The hematocrit value, they are almost above 55% in the male and 47% in the female. Apart from that, you will see leukocytosis. There will be basophilia. Along with that, you will see raised neutrophil alkaline phosphate scores. So the treatment is to maintain the normal blood count and relieve the symptoms. Apart from that, Phlebotomy can be done, that reduces the total blood cell mass and induces a state of iron deficiency. Anticoagulant therapy can be given. Anticoagulant could be given. Chemotherapy can be given in order to induce myelosuppression. Hyperuricemia. The major complication and cause of death in polycythemia vera is vascular thrombosis. The next condition is essential thrombocythemia. It is also known as essential thrombocytosis. Here there will be increased platelet count in absence of any recognizable stimulus. Unlike in case of reactive thrombocytosis that occur in response to stimuli like chronic infection, hemorrhage, post-operative stage, chronic iron deficiency, malignancy, rheumatoid arthritis, this essential thrombocytopenia, it is due to the overproduction of the platelets from the megakaryocyte colonies without any stimulus. So the underlying pathophysiology mechanism that involves the absence of control by thrombopoietin. So that regulates endomitosis in megakaryocytes to produce platelets. So that results in uncontrolled proliferation of megakaryocytes as well as platelets. Now the typical clinical features would be, it is more seen in the older individual. There would be bleeding, excessive bruisability following a minor trauma, and there could be transient ischemic attack or stroke can occur. So there is an elevation in the platelet count above 4 lakh. On blood film, you will see large platelets, megakaryocytes, fragments, etc. On a bone marrow examination, that would reveal a large number of hyperdiploid megakaryocytes and increased fibrosis. The treatment, it is run a benign course and may not require therapy. Treatment might be indicated if patient require if the platelet count is more than 1 million. The next disease is chronic idiopathic myelofibrosis. So here you will see proliferation of neoplastic stem cells at multiple sites outside the bone marrow, especially in the liver and spleen. So it develops in association with well-defined marrow disorders or as a result of toxic chemical agents or irradiations. The exact etiology is unknown. It affects in the middle age. You will see clinical feature, you will see anemia, fatigue, weakness, splenomegaly, abdominal discomfort, fatigue and bleeding. There would be mild anemia, leukocytosis that may turn into leukopenia. There might be thrombocytosis initially, but with the advanced cases it shows thrombocytopenia. Peripheral blood smear may show bizarre red cell shaped teardrop poikilocytes, basophilic stippling. So these are the features. The bone marrow might show dry tap, increase reticular networks, etc. The treatment, it does not require any specific therapy. Anemia and ineffective erythropoiesis, they are difficult to treat and they don't respond to erythropoietin. The next is a myelodysplastic syndrome. So it is a group of hematopoietic clonal stem cells disorder. There you will see abnormal marrow elements. So it is idiopathic with risk factor including radiation and benzene exposure. Secondary conditions may occur following anti-cancer or aplastic anemia therapy. It is more common in older adults with a slight male predominancy. Features include anemia, fever, weight loss, splenomegaly. On laboratory findings, you will see 2 or more blood cell lines by your pancytopenia.